What's up?
First of all, we have to briefly recall the etiology of polycythemia. Recall that on chromosome 9 located JAK2 gene that encodes JAK2 kinase. The function of JAK2 kinase is to activate cellular pathways that are responsible for cellular proliferation, mostly of myeloid cells, and activation of pathways occurs by phosphorylation. By activation of JAK-STAT pathway, JAK2 kinase stimulate mostly red blood cells production. By activation of PI3K-AKT pathway, it stimulates the production of megakaryocytes, from which platelets are formed. By activation of RAS pathway, it stimulates the production of granulocytes and monocytes. And in normal condition, JAK2 kinase is active only when it receives signal by cytokines. Kidneys produce erythropoietin that stimulates red blood cells production. Liver produces thrombopoietin that stimulates production of megakaryocytes from which platelets are formed, and bone marrow microenvironment by secretion of granulocyte macrophage colony stimulating factor cause increase in production of granulocytes and monocytes. But if mutation cause substitution of valine on phenylalanine in 617 position of JAK2 kinase, now JAK2 kinase becomes constantly activated. So this regulation by cytokines is gone, and this mutation causes disproportional activation of intracellular pathways that results in mild increase in granulocytes and monocytes, moderate increase in platelets, and severe increase in red blood cells. With increase in red blood cells, hemoglobin concentration and hematocrit will also proportionately increase, and erythropoietin concentration will proportionately decrease. And the diagnosis of polycythemia is made based on increase in red blood cells, hemoglobin, and hematocrit, panmyelosis with pleomorphic megakaryocytes, based on the presence of a mutation or mutated JAK2 kinase, and low erythropoietin level.
Now what?
The first analysis that we see is complete blood count. So it's a normal blood analysis, and it's analysis of a patient with polycythemia. First of all, we see the extremely high red blood cell count, because recall that JAK2 kinase mutation substantially increases the proliferation rate of myeloid cells. So with time, the amount of myeloid cells progressively increase. But because JAK2 kinase mutation stimulate mostly JAK-STAT pathway, the amount of red blood cells increase the most. And actually, you can hardly find any pathology that can cause such huge increase in red blood cell count. So we can say that it's a unique feature of polycythemia.
That's very interesting.
Recall that such huge increase in red blood cells is responsible for major clinical symptoms of polycythemia. It's deep venous thrombosis that with time can cause hepatomegaly and splenomegaly, visual disturbances, CNS symptoms, hypertension, tissue swelling with skin redness that together form so-called plethoric complexion, and its work hypertrophy of the spleen that causes splenomegaly. Because the amount of red blood cells in peripheral blood increase, the amount of hemoglobin that we determine will proportionately increase, because hemoglobin is a component of red blood cells. Recall that red blood cells inside them contain hemoglobin. Hemoglobin consists of heme and globin, and heme consists of iron and protoporphyrin. So if hemoglobin synthesis is not disrupted, with increase in red blood cells, hemoglobin will also increase. And as we see, 217 hemoglobin is huge. Also with increase in red blood cells, hematocrit will also increase. Hematocrit is basically the percentage of red blood cells in the blood. Recall that hematocrit is equal to red blood cells multiplied on MCV divided on 10. So obviously, with increase in red blood cells, hematocrit will increase. And as we already know, the presence of increase in red blood cell count simultaneously with elevated hemoglobin level more than 165 in men and 160 in women, and also increase in hematocrit more than 49 in men and 48 in women, is one of the three major criteria for polycythemia.
3 Gläser.
Because JAK2 kinase mutation causes only minimal stimulation of RAS pathway, the amount of granulocytes and monocytes only slightly increase. and as we see in complete blood count, the amount of white blood cells is only slightly elevated, mostly due to the increase in segmented neutrophils. Basophils are also slightly elevated. Interesting that they can even remain within normal range, but the problem is that in polycythemia they become hyperreactive, and because of this they release a lot of histamine that with time can increase the risk of gastric ulcers. And in addition to this, increase in histamine release in tissues cause aquagenic pruritus, which is a signature feature of polycythemia. Another type of cells that significantly increase are platelets. Because recall that JAK2 kinase mutation causes significant stimulation of PI3K-AKT pathway, as a result the production of megakaryocytes substantially increase. And because from megakaryocytes platelets are made, with increase in megakaryocytes, the amount of platelets in peripheral blood increase. Such significant increase in platelets greatly increase the risk of arterial thrombosis that can lead to erythromelalgia, but also huge increase in platelets production can end up in production of broken platelets that will not be able to provide effective primary hemostasis, and this will greatly increase the risk of bleeding. If we determine pathological alterations in complete blood count, the next option is bone marrow aspiration or bone marrow biopsy. The problem with complete blood count is that it's not so accurate method. The most obvious example are megakaryocytes. We say that in polycythemia the amount of megakaryocytes increase, and only because the amount of megakaryocytes increase, platelet count will increase. But in complete blood count, we don't see megakaryocytes, we can see only platelets. The concept here is that by complete blood count, we determine the amount of cells just in peripheral blood. Recall that cells are produced in the bone marrow and only after they enter into the blood. So because cells are produced in the bone marrow, the amount of cells that we determine in the bone marrow tell us about the current state more precisely than the amount of cells that we determine by complete blood count. So complete blood count is definitely more commonly used, because it's non-invasive, easy to do method. Bone marrow aspiration is more invasive but much more precise. So once we see something pathological in complete blood count, we refer such patient for bone marrow aspiration, where we're interested in state of bone marrow production capacity.
Nice one.
So in hematopoiesis, for example, we see that JAK2 kinase mutation causes increase in production of megakaryocytes that cause increase in amount of platelets in peripheral blood. But we don't see megakaryocytes in the blood because they are too large cells to leave the bone marrow. And to see what is going on in the bone marrow, we have to do bone marrow aspiration, where we can determine the amount of megakaryocytes, but the amount of platelets we can simply determine by complete blood count. And in polycythemia, on bone marrow aspiration or with bone marrow biopsy, we can determine the overgrowth of 3 myeloid lineages, which are erythrocytes, thrombocytes and granulocytes with monocytes, this condition called panmyelosis. And also in polycythemia, on microscopic examination, we see that megakaryocytes are fully mature and all different in size, so-called pleomorphic, and it's another major criteria of polycythemia. But to say for sure that it's polycythemia, we have to find the particular mutation that causes this disease. For this purpose, we use molecular analysis. By molecular analysis, we can find the genetic mutation that causes formation of mutated JAK2 kinase. It's JAK2 exon 12 mutation, which is basically the mutation in DNA molecule, or the presence of mutated JAK2 kinase itself, which is JAK2 kinase with phenylalanine in 617 position. Another crucial test that we use is the evaluation of erythropoietin level in the blood. Recall that bone marrow produces red blood cells, and the production of red blood cells is regulated by the kidneys that secrete erythropoietin that greatly increase the rate of red blood cells production. But in polycythemia, because mutation forces bone marrow to produce huge amount of red blood cells, there is no need for kidney to provide additional stimulation of red blood cells production. So secretion of erythropoietin by kidney decreases proportionately to increase in amount of red blood cells in the blood. So in polycythemia, where we have huge amount of red blood cells, secretion of erythropoietin is extremely low, and low erythropoietin level is a minor criteria of polycythemia.
You forgot one very important thing, mate.
Also, the signature feature of polycythemia is low ferritin level. To explain this, we have to know that ferritin is basically a protein called apoferritin that contains a lot of iron molecules, and together they called ferritin. And in our organism, ferritin is a major depot of iron. Red blood cells have inside them hemoglobin, which is the major functional component. Hemoglobin consists of heme and globin, and heme consists of iron and protoporphyrin. So to produce red blood cells, we have to take iron from ferritin and to put this iron inside the hemoglobin. As we said, JAK2 kinase mutation in polycythemia force bone marrow to overproduce red blood cells. So the higher will be the production of red blood cells, the more hemoglobin molecules we need, thereby the more heme molecules we have to produce. So the higher will be the amount of ferromolecules that we will take from the ferritin. So because in polycythemia we have hyperproduction of red blood cells, the amount of ferritin is very low.
Ah, well, I won't be making that mistake again.
And in addition to this, we have to note that in polycythemia, the coagulation tests are not working properly. And the reason is that during coagulation studies, increase in red blood cells cause citrate overload that cause significant alterations in results of coagulation tests.
Great. Fine. Yep. Ciao. What's that mean? Ciao. It's Italian. Means food.